Welcome to the Brain Matters webinar. I'm Dick Moberg, your host for today's presentation. Our featured panelists are Deborah Hemmerle and Laurence Child from the Zuckerberg San Francisco General Hospital. They'll be talking about a new protocol for managing spinal cord injured patients. And we have a guest appearance from Dr. Geoff Manley, who will introduce the topic. As usual, we will first review a few upcoming meetings and then get right into our recorded presentation. At the end, we'll have a live question and answer session with our panelists. So please type in your questions using the Q&A tab on your screen anytime during the presentation. Now let's look at some upcoming meetings. All of these meetings are listed in the events section on our website, www.moberg.com. Next week, we have the subarachnoid hemorrhage meeting, formerly vasospasm, in Amsterdam, followed by the neurotrauma meeting in Pittsburgh. Look for us at both of these meetings. At the same time, the International Conference on Spreading Depolarizations, held by COSVID, is happening in Japan. The EEG Technologist meeting is in Kansas City in August, followed by the ICP meeting in Leuven. You've all heard of Randy Chestnut's Best Trip trial with ICP. We'll be holding the Beer Best trial in Leuven. Later that month is the SNAC meeting in Phoenix. And now a few abstract deadlines. Here are some deadlines. I won't read them. Check them out on the recording of this webinar, which will be on our website next week. This is a good time to remind you about our newsletter, the Neuroscience Monitor, which will keep you up to date in neuromonitoring. Your colleagues can sign up anytime on our website. If you have an event or news item related to neuromonitoring and neurocritical care, please send it to us. We also may be limiting our use of other email blasts, such as from NCS. They're getting pretty expensive these days. So this newsletter may be your only source of info on our upcoming webinars. So tell your friends. So before we go to our presentation, I wanted to tell you that I just found out that I met one of our presenters, Deborah Hemmerle, many years ago. She was dressed in a banana suit at Burning Man. She was one of the founders of Camp Orange, whose theme is bananas. Figure that out. And she actually got married there. I had the pleasure of meeting her husband, Jason, while filming this webinar. Deb is our first webinar panelist, who is also a burner. So history's being made today. So let's go to our presentation. When we were filming the webinar, Geoff Manley walked in and was gracious enough to provide his perspective on the latest in managing brain and spinal cord injury. So let's get going.
Welcome to windy San Francisco.
Yes, Mark Twain said the coldest summer he ever spent was in San Francisco, and here we are outside of San Francisco General Hospital on June 19th. And what, Dick, it's about 63 degrees and windy, but we're glad you could join us today for this webinar.
Yeah, so my name is Deborah, and I'm a critical care nurse here at Zuckerberg San Francisco General. I'm also a research nurse in the UCSF Brain and Spinal Injury Center, which is housed here on campus, and I work on the TRACK SCI study through that department.
And she's very modest, but she's also working on her PhD at UCSF right now. I'm Laurence Child. I'm also a critical care nurse in the neuroscience unit, and I'm a clinical nurse specialist. I manage quality for our neurotrauma program. So we're a trauma center, and we serve 1.5 million people, a relatively small amount, from the city of San Francisco down to about San Francisco Airport. We see what, about how many traumas a year here?
Just about 4,000 traumas we treat annually, which is about 1 in 8 San Franciscans.
Yeah, it gets seen by us.
Year.
And we're the safety net hospital too, so we're very loved in the community and play a big role in it. We do neurotrauma. We see about 50 to 70 spinal cord injuries a year, and that's what we're going to talk about today.
So my name is Geoff Manley. For the last 20 years, we've been trying to really push the envelope, if you will, of how we're taking care of traumatic brain injury patients with the introduction of things like brain tissue oxygen monitoring, working with cerebral blood flow monitoring, thinking about things like compliance pressure measurements. And so with all of these advanced tools, one of the things that we've needed in order to succeed is a way to really harness this information and pull it together. And so the CNS system has really allowed us to do that. And so much in the same way that we've tried to pioneer new approaches to taking care of traumatic brain injury, recently we've turned our attention to spinal cord injury. And as you know, spinal cord injury remains a devastating problem. And unfortunately, it's not just a problem that affects those young males that we traditionally saw 15, 20 years ago, but it's really rapidly growing within the elderly population. So this is something that actually is probably, even though we've seen a slight decrease over time with the kinds of things that we've had with seat belts and so on, and the way we've improved motor vehicles, I think unfortunately we may start seeing an increase in this with the increasing elderly population that's much more mobile than they used to be. So much in the same way that we really wanted to start to push the management of traumatic brain injury beyond simply just looking at their coma score and looking at their pupils and thinking about what else could we do besides intracranial pressure monitoring, we started thinking about things like how do we measure blood flow and perfusion in the spinal canal? Because essentially the spinal cord is an extension of the brain, or the brain's an extension of the spinal cord, depending on your perspective. And so what we began to think about is, in the same way that we were measuring cerebral perfusion pressure to have a surrogate for flow, could we do the same thing in the spine? And so fortunately, we had pioneering colleagues that were already looking at this and putting in lumbar catheters in a variety of models, which allowed them to look at the pressure within the thecal sac, look at the mean arterial pressure, and from that, much in the same way that we get a cerebral perfusion pressure, to calculate a spinal perfusion pressure. So we had been mulling this over and thinking about this, and there had been a number of interesting papers that were coming out of England from a colleague of ours, and we began to think about this, and as one of my professors once taught me, the difference between, not doing something and the first patient is infinity, and then between the first patient and the second patient is 1, and the second and the third is 1. So we knew that at some point we needed to get started to try to do this, because we know that a lumbar puncture and a lumbar subarachnoid drain, which we do for cerebral spinal fluid leaks and things of this nature, really have a low morbidity profile. And we had seen the value of this, and as many other things, the thing that just stops you from doing this is starting to do it. So I was on call one weekend, and we had a patient that came into the hospital who unfortunately had suffered a spinal cord injury from a surfing accident, and at the time was unable to move his arms and legs. And as I began to speak with the patient, I could tell that the patient was pretty informed about things, and I asked him what he did, and he said, well, I'm an emergency medicine physician. And so we explained to him this notion that we could put a lumbar subarachnoid drain in him and start to measure the pressure within his spinal canal and use that to measure the spinal perfusion pressure. And if you ever get a chance to meet this patient, you'll know what I'm saying. And, his response to me was, let's go for it. And so we then proceeded to put this catheter in. We hooked it up to our CNS monitors, much like we would do as if we were going to measure cerebral perfusion pressure, and essentially began to look at that pressure within the canal and associate that with the mean arterial pressure, such that rather than just simply trying to do a blanket, mean arterial pressure greater than 85, which had been our practice, we were now able to start to look at a spinal perfusion pressure. So if you roll forward today, we've had a number of patients now that we've been doing spinal perfusion pressure measurements in. And what this allows us to do is to actually now try to titrate this to the specific individual. So one way to think about this is that by doing this kind of approach, it allows you to deliver personalized care to that patient in front of you. And that's aided by the use of us being able to aggregate all this data together on the CNS monitor. So what we do today, and some of the other folks in the webinar are going to show you some examples of this, is we collect the spinal perfusion pressure by looking at the intrathecal pressure and by looking at the mean arterial pressure and deriving this value. What's been the value of this? Well, I think it gives us a better understanding of what is the perfusion pressure of that cord. It's allowed us in some patients to use less pressors, which we know that from some of the papers that we've written here previously, is that pressor use does have side effects and complications. And so by using less of this, we believe that we're delivering better care. So with this, I think this is just the beginning of a new era of monitoring function in the spine. So, in the coming years, what you're going to see is by using this ability to aggregate this data, we're going to be bringing on new endpoints. So, for example, one of the things that we're interested in is looking at motor evoked potentials and how these motor evoked potentials are associated with this spinal perfusion pressure. And this is nothing new. When we're in the operating room and we're doing spine surgery, we often tune the blood pressure to these motor evoked potentials. And so the ability to do this not only in the operating room, but to bring this technology back to the intensive care unit will help us to better add a physiological or a functional measurement to this pressure measurement that we're using today. We're also looking at the future of using expansive duroplasty. So much in the same way that 20 years ago we started doing decompressive hemicraniectomies and allowing the brain to swell more, the idea of being able to open the thecal sac or the dura surrounding the spinal cord, putting a patch in there to allow that to expand and to swell naturally when we really don't have very good drugs for CNS swelling, I think is another approach that we'll be looking at. So, beyond that, there's a lot of work that's happening for these patients in brain-machine interface, and we believe very, very strongly that in order to identify those right patients for those early types of brain-machine interface studies, this actually needs to happen in the ICU. So all of this actually fits in to a comprehensive program of more intensive monitoring, not only of the brain, but as you see today, emerging in the spinal cord, how we put all these things together to ultimately deliver better care to our patients. So I appreciate you guys joining the webinar today. I think that there's a lot of great things afoot, and none of this happens without nursing support. So we can have good ideas, we can work as a partnership and as a team, but unless this care is delivered 24/7, which is really what the bedside professionals do, none of this is possible. So thank you for your support of the patients and the care as we pioneer new treatments for spinal cord injury.
All right, thank you so much for coming and listening to our webinar today. Today we're going to talk about spinal cord perfusion pressure, a new protocol for hemodynamic management of spinal cord injury. My name is Deborah Hemmerle. I'm a nurse at San Francisco General Hospital, and I also work as a research RN for the TRACK SCI study, which runs through the UCSF Brain and Spinal Injury Center. So I was working on putting the slides together for this presentation and looked over at my bookshelf and saw all my old nursing textbooks, and I thought it'd be interesting to look up in the textbook that I use for nursing school what it said about spinal cord injury management. There's been so much great literature that has come out in the past 10 years, and it's interesting. This book was published in 2004, and it says, spinal cord injury continues to be a devastating event, but new treatment methods are continually being investigated, which is still true today. But if you read a little further, it really doesn't say anything about hemodynamic management of these patients. It did talk about the fact that in the first 2 weeks, blood pressure can be unstable and quite low, but doesn't say anything about how we can treat that or the outcomes that are associated with hypotension or the management that nursing can do to prevent secondary injury. So in the past 10 years, we've really learned a lot about this injury, and particularly with the cardiopulmonary management of acute traumatic spinal cord injury, we know that it's broken down into two different phases. There's the acute management, which includes the initial resuscitation of the patient, and the stabilization of the spine, which includes early decompression. For prevention of secondary injury, the focus of patient care there is to be able to prevent ischemia, hypoxia, and edema, so pretty much anything that can result in death of the nerve cells. According to the American Association of Neurological Surgeons and the Congress of Neurological Surgeons, they do have a recommendation pathway for how to treat the cardiopulmonary sequelae following spinal cord injury. So acute management, they recommend early decompression and then admission to an ICU setting so that there can be continuous hemodynamic monitoring, as it's been shown to improve patient management itself and then also lower morbidity and mortality following acute spinal cord injury. As far as prevention of secondary injury, continuous cardiac and respiratory monitoring is recommended so that hypotension can be corrected as early as possible. They recommend keeping a systolic blood pressure below 90 and maintaining a mean arterial pressure of 85 to 90 for the first 7 days. This prevention of secondary injury is where we'll be focusing on for our presentation. So what do we know about hypotension in acute traumatic spinal cord injury? Well, it's caused by hypovolemia and or just the direct spinal cord trauma itself. We also know that there's a loss of peripheral vascular resistance below the neurological level of injury, causing increased hypotension. And why do we care about this? Well, hypotension in acute traumatic spinal cord injury is associated with worse outcomes. We know that from laboratory evidence, hypotension contributes to secondary injury after acute spinal cord injury by further reducing blood flow to the spinal cord. Hypotension in animal models have also resulted in worse neurologic outcomes. And we care because we know that aggressive hemodynamic management of spinal cord injury is associated with better neurologic outcomes in clinical studies in humans. There are various clinical studies done in humans that show that that consistently report that volume expansion and blood pressure augmentation in the ICU are linked to specifically improved ASIA scores in patients with acute spinal cord injury. So what's the goal as far as how we manage it? Well, keeping the systolic above 90 and a MAP between 85 and 90 tends to be the standard across the board. For those patients that are able to be admitted to an ICU, it's preferred that they can get the critical care level of nursing care, that an arterial line can be placed, and that we can have advanced monitoring to be able to manage this patient as they're in the ICU and as hypotension may be evolving. We usually need to use vasopressors in these patients so that we can keep their blood pressure within range. But we also do know that vasopressors are associated with other negative side effects following that. So being able to have a better, more targeted way of managing the blood pressure in these patients would be ideal. So as far as the bedside management, we can really look at how we've been managing traumatic brain injury up until this point. We've been doing this for a couple decades now, and it's really become a standard of care that we track the mean arterial pressure and have intracranial monitoring in place so that we can manage the intracranial pressure and be able to calculate the cerebral perfusion pressure from that so that we can build more targeted treatments. Well, with spinal cord injury, we don't really have a standard met yet that's across the board. But conceptually, we can bring that into a model that makes sense. So instead of looking at the intracranial pressure, we can think about the intraspinal pressure and how that can have an effect on a spinal cord perfusion pressure. Now, the goal of maintaining a MAP of between 85 and 90 is so that it can maintain a spinal cord perfusion pressure within a range that would ensure that there's no cell death. So the reason why monitoring of MAPs in spinal cord injury is so important is because we want to make sure that there is adequate spinal cord perfusion pressure to prevent further injury. Well, if there's a way to monitor the spinal cord perfusion pressure itself, then we probably can have better targeted treatments and maybe even prevent the use of excessive vasopressors in these patients. All right. So with calculating a spinal cord perfusion pressure from a mean arterial pressure and an intraspinal pressure, we're able to more directly target the treatment of these specific patients instead of using a marker of spinal cord perfusion pressure like the mean arterial pressure. Maintaining a spinal cord perfusion pressure within an adequate goal can ensure that these patients are within a range that is associated with more improved outcomes. So we look at these two studies that were published in 2016 and 2017 that really give us a pathway for how to treat these patients. So Dune from London in 2016 published a paper describing the pathway on how you could treat a patient using an intraspinal monitor and how we can calculate the spinal cord perfusion pressure. And also was able to show a strong correlation between a high intraspinal pressure or a low spinal cord perfusion pressure and reduced neurological recovery. This suggests that interventions that can increase spinal cord perfusion pressure within our goal range may be able to actually improve neurologic outcome or be associated with less worse neurologic outcomes. Square in 2017, with a study that was done in Canada, actually was able to bring these findings into a study that showed that an SCPP above 50 is a strong predictor of improved neurologic recovery. They had a sample size of 92 patients, and they made it their standard of care to insert these monitors into their spine in order to get a spinal cord perfusion pressure that could allow them to titrate the vasopressors to a more targeted range for that patient.
So I'm Laurence Child, and I work for the Department of Neurosurgery here at Zuckerberg San Francisco General doing quality management. So a lot of my work is working with the nurses in the ICU and benchmarking and tracking our various goals. So this is, thanks, Deb, it was really exciting that there's a really cool piece of research that clearly we thought was going to affect our practice. And as Geoff talked about earlier, a lot of what we're about is bringing research to the bedside. And of course, it sounds a lot easier than it is. One day a great paper comes out, our department makes a decision that we want to try this, and we try it and it works, but it's more than just implementing something by fiat. It requires a lot of different professions being made aware of it and buying into it and participating in it. So we practice here in our trauma program within the context of evidence-based guidelines. And we do that for a number of reasons. Most importantly, it ensures that everybody receives the highest quality evidence-based treatment. It improves quality and reduces harm. And having guidelines helps us to facilitate performance improvement. So when we have guidelines, we can track things, we can benchmark them, and we can improve year after year. Additionally, it facilitates a multidisciplinary approach to treatment. So spinal cord injury is a very complex disease that involves a lot of specialties, not just the surgical management and the postoperative management, but obviously nursing care is a big chunk of it. Respiratory care is particularly important. We have all of our rehab specialists from physical therapy, occupational therapy, speech pathology, physiatry plays a critical role in assessment and then planning for the future for these folks. Also spiritual care and behavioral health. These injuries are quite devastating and require a big team of people to make them happen. Lastly, one thing that we've been very concerned about here at ZSFG is reducing racial disparities. And it's our view that using a guidelines-based approach to treatment helps reduce disparities between ethnic, racial, linguistic, and cultural groups. Our spinal cord injury guidelines, we started developing them in 2014 and based the model off of our TBI guidelines. After about 18 months of work, they were ready to implement in 2016. We had all the specialties involved review the relevant literature and make recommendations. We carefully assessed how the implementing these guidelines was, what effect it was going to have on patient flow from the ED to discharge. And we also took the design of our brand new hospital into consideration as we were developing them. The main point here is delivering coordinated care. The left hand needs to know what the right hand is doing in order to make this work. So our pathway for the clinical care of acute traumatic spinal injury starts when the patient arrives in the ED. If there is suspected cord injury, then two things happen. First, the neurosurgery service is notified, and meanwhile, the normal trauma pathway starts, which involves their primary assessment, a fast exam, CT scan, and then to the MRI. At this point, neurosurgery should be there within 15 minutes to assess the patient and review the MRI imaging. Resuscitation revolves firstly around ensuring adequate volume with crystalloid resuscitation, and our goal is to have a MAP of greater than 85 and a systolic of greater than 90. Following that, we'll begin a pressor. Norepi is the preferred agent, and at this point, the patient is assessed for surgery. If surgery is indicated, our goal is that it happens within less than 12 hours after injury. The best practice, we think, is to go from the CT scanner to the operating room. If that's not possible, then we'll take the patient up to the intensive care unit for monitoring by Neuro ICU nurses until the OR is ready. So this approach for ultra-early decompressive surgery comes from research that was done here a couple years ago. And again, the goal being less than 12 hours. In San Francisco, at San Francisco General, that happens usually at less than 8 hours. There are two big considerations that happen here. One is having the appropriate OR team in place. So unlike a trauma situation that would involve massive bleeding and emergent surgery, we do have some time to wait, and it's thought by our surgeons to be more important to ensure that we have the experienced and appropriate OR nurses and technicians on hand for spinal surgery. So that might be a reason for delay. Another one is family process. So some families are not willing to consent right at the moment. And it may take them an hour or two to collect or have their spouse come or to make a decision. And we're able to support that by caring for the patient, maintaining adequate hemodynamic parameters in the ICU. So let's take a look at a patient. So San Francisco is a marvelous place to live. The photograph here is of Ocean Beach and a guy surfing. I live a few blocks away from there. My surfing days are long over, but I do like to go out and watch. And it's quite beautiful, and as you can see, it's not without its hazards. So our patient came in late 2017 after we had, as a team, had decided to try our new approach to hemodynamic management. So he's a 37-year-old male. He fell while surfing. He was found pulseless and brought to shore, and he had a return of circulation after one round of CPR. The nice thing about San Francisco being a small city is chances are you're going to run into somebody who works at this hospital, and indeed there was a nurse who works in the emergency department of this hospital who was also surfing that day and was the one who started CPR. So very fortunate for everybody. The other nice thing is that we live in a very small place. The average response time for an ambulance here is about 7 minutes, and it doesn't take much longer than 7 minutes to get from anywhere in this city to this hospital. The beach there is less than 6 miles away by road, so it's quite a quick journey indeed. So our patient came in and was found to have T2 signal changes in the C3, C4 area. And his exam was problematic, so no strength in the upper extremities, minimal strength in the lower extremities, and no sensation below T4. So this would make him a C3 Asia C. He went to the OR for a C3 to 5 laminectomy and 2 to 6 fusion, and was brought up to the ICU for neuro assessments, nursing care, and hemodynamic management. So Geoff Manley was on service that week, and he brought, the next morning, the patient was able to be extubated, and Geoff had a talk with him about trying this new protocol. And so the lumbar catheter was placed at the bedside, and we initiated a goal of greater than 65 for the spinal cord perfusion pressure. So just to remind you, as Deb said, the spinal cord perfusion pressure is the MAP minus the intraspinal pressure. we zero both the catheter and the transducer at the phlebistatic axis. So this one often causes a little bit of people to be a little bit perplexed when they think about the choice of that. In all frankness, we chose this because that was what they did in Square's protocol. And it is a nice and easy way from an hour-to-hour management at the bedside if you have both of the catheters in the same place. So both the arterial blood pressure and the interspinal pressure catheters zero to the phlebistatic axis. And we approach this from a blood pressure management only, so no draining of the lumbar catheter, only using norepi to ensure that we were within goal. So the lumbar drains are very familiar to nurses. They can be placed either at the bedside or in the OR. They're safe. The nurses know the system very well because we use them in the neuro ICU for CSF leaks, dural tears, and after the TEVAR procedure. There are a few differences in terms of monitoring ICP. The big one is that we're actually going to transduce a lumbar pressure, which we normally don't do. But because it's the same physical system as ICP, it made it quite easy. And the other thing was that we don't drain it as part of this protocol, so that was a little bit of change for the nurses. And there's a big role for the nurses at the bedside. First of all, safety is obviously the biggest one. And nurses, by and large, are very concerned with safety, and particularly, to be frank, conservative in that approach. If there's something new that's happening and something that's not well understood, as a profession, we like to ensure that we know it well because the patients don't know it well. And so we wanted to know, has the patient been adequately consented for this? What are the best practice around it? Should the patient be flat? Is it okay for them to be at a 45-degree angle? What was the rationale for measuring at the phlebistatic axis? Why aren't we draining, and how do we go about monitoring this? So these are all questions that we needed to answer in the process of introducing this. We model our management after CPP. The system is analogous to monitoring CCP. Our current tech supports CCP designation, so we use continuous calculation of CPP with the Philips monitor, and that gets transferred over to our Moberg CNS monitor and the Moberg CNS reader. So a little bit tricky in that we don't yet have the quite labels for it, but not an insurmountable problem. So let's look at some data with this patient. So the first graph at the top shows us a trend line of the patient's arterial blood pressure. And then if you see, there are some pie charts underneath here, which give us the total time that his mean arterial pressure was above 85, and also the shift time that he was above 85. And we know that green is good and red is problematic. And we can see that our patient, for his total stay, was 17.9% of the time out of range. When we look at the bottom, where it's labeled CPP, but should be read SCPP, spinal cord perfusion pressure, we see a better picture here. The total time that he was not within our goal of greater than 65 was only 11.7%, and in the shift was 13.1%. So this is pretty interesting, and what it's showing us is that we don't need to have this patient at a MAP of 85 in order to achieve our spinal cord perfusion goal pressure. And in practice, what this meant was a lower usage of pressors on this man. So by limiting pressor use in the young, we're reducing risk of ARDS, and in the old, we're reducing risk of cardiac complications. So we see that as a great benefit to the patients. So this represented a significant practice change for us. After our first case, we decided that we would adopt this for all patients with ASIA ABC scores, and those with ASIA D would be considered on a case-by-case basis by the attending on duty that day. So we reviewed our guidelines in early 2018, modified our order sets, we communicated our practice change to all the disciplines involved, and there were some challenges. So the biggest one is, how do you communicate to all the staff about this? We have more than 100 nurses who work in our ICU, dozens of other professionals, and new things can be challenging. I think one of the best ways to get people involved is through the power of story, and this was a particularly good and rewarding story. Our patient was or is an emergency physician in the area, and he was an incredibly nice guy and incredibly excited about participating in this. And as you can see from these photos, he had an incredibly good outcome. Following this, he wound up returning to the community, working very, very hard in rehab, and has now returned to work. He's come back to visit us and spoken at a number of things, and articles were done on him in the news and the newspaper, so he's been a great advocate for spinal cord injury, and particularly for innovative approaches to treating it. This helped to get everybody in our department on board and excited about it, so it was a very exciting time to be it. Can we say that his good outcome was the result of this single change in our practice? I think absolutely not. But what we can say is that this is a part of it. It's one piece of it, and we're very proud of it and very proud to have adopted it, and it's very encouraging. And we've continued on with other patients, and using this kind of data-driven approach, we get better and better at it. So this was a patient that came in about 6 months later, and we can see here that our arterial, in a similar way, our arterial blood pressure goal was not met as much of the time as our spinal cord perfusion pressure goal was. But the window keeps getting narrower and narrower as we move along. So when Deb and I work at the bedside, it's kind of a fun, never underestimate the power of intermittent reinforcement. So when you look at that pie chart and say, man, I think I can do a better job than we did overall, just make the graph look prettier shift by shift. It has a pretty good effect on things and is a really innovative way to be looking and to be managing the patient at the bedside hour by hour. So it's exciting to be a part of, and it's a real privilege to be a part of. The reason why we do this is for these guys. So this is our patient. He is an artist as well as a surfer and a doctor, and he's returned to work and explored the changes that have happened in this body afterwards through his art, which is really quite profound. And in the end, that's why we do what we do, is restoring people to health. And this is a particularly exciting time in spinal cord injury because we're able to incorporate all of these new technologies and new approaches to our work.
Thanks, Deb and Laurence, for a wonderful presentation. Really, really enlightening. And so once again, please send in your questions. We will now go live to the Zuckerberg San Francisco General Hospital for our Q&A session. And actually, Laurence is not available to join us today because of some tooth problems. So we'll be talking to Deb.
Yeah, unfortunately, Laurence can't be here. He had to go to the dentist urgently. So just me today. I'll do the best I can answering your questions. Let's see what we got. All right. So how might the placement of a lumbar catheter impact patient mobilization? Great question. Have you at least anecdotally observed any negative changes in secondary outcomes like skin breakdown, pneumonia, or ICU hospital length of stay? So we've been doing this protocol for about a year, and I haven't, in my personal experience, I haven't noticed any changes. We can definitely mobilize the patient, and we encourage early mobilization as soon as possible, spinal cord injury. So as soon as we can get them sitting up at the edge of the bed or even standing at the edge of the bed if they're like a AISD, then we do that as soon as possible. catheter is just taped to the back and kind of up to the shoulder, so it's very secure. I haven't noticed any sort of skin breakdown or any leaking, and I actually have never, to my knowledge, we've never had to replace a catheter for it becoming dislodged or anything like that. Pneumonia, I'm not really sure on that. I don't know. It depends on, if we have vent-dependent patients, and I think there's a lot of other factors with that. As far as ICU hospital length of stay, this is definitely anecdotally, but I do think that it has an impact on the length of ICU stay. It'd be really interesting to look at, because I do think we can wean these patients off pressors faster. They tend to just have a lower pressor requirement because we're not trying to meet that really high MAP goal. And so in my experience, we've been able to wean them off sooner. It'll be interesting to see as more data comes out. All right, the next one, let's see. Is there a comparable waveform to ICP in an EVD or both? Yes, actually. So it's the same sort of closed system, and so you get pretty much the same waveform that you do when you're doing ICP monitoring. So you get the P1, P2, P3 wave, and it looks relatively the same. We don't drain at SF General, so we keep it closed, so it's always to the transducer. Reduction, have you seen a reduction in use of NoRepu by implementing this protocol? So I really am interested to look at the data. I think if I were to guess, since we've started this new protocol, it would be maybe around 80 or 90 patients that we've treated with this. So not that many, but definitely enough to go back and see if the pressure requirement is different now that we're looking at SCPP versus just CPP. In my anecdotal experience, I do feel like it is less, but it'll be interesting to see once we can get more literature out there. How much additional training did the bedside staff, i.e. nursing, have to go through before implementing this protocol? So I think Laurence touched on it a little bit, but it was actually surprisingly easy because we are already used to titrating vasopressors to a MAP goal or a CPP goal, and we're used to the same equipment that's used to transduce the intraspinal pressure as intracranial pressure. So the setup is the same as far as the equipment. And the catheter is just like a lumbar drain. So the management for the nurses is relatively easy. There was some additional education needed because unfortunately our Philips monitors aren't up to date. So we don't have the labels for spinal cord perfusion pressure or intraspinal pressure. And so what we kind of just decided to do in our hospital is label intraspinal pressure as intracranial pressure, because that's the closest label that Philips monitor gives us. And then label SCPP as CPP. So the nurses have to know to transition those labels in their charting to the correct label. And then, it's not uncommon to get a spinal cord injury and a TBI, a traumatic brain injury, in the same patient. And so then kind of navigating how we label that, just logistics wise. But it's been interesting to see the encouragement in the nursing staff, especially since we've had the patient who's been very open about his story and coming back to visit the nurses. And, as an ICU nurse, it's always great to see kind of what happens afterward, and you feel like you can really affect the outcomes of the patient. So, all right. Let's see. How often do you calculate SCPP at Zuckerberg San Francisco General? Well, fortunately, because we relabel, we use the old labels in the monitor, we just get a continuous measure of CPP because we have the arterial line running. And so we can see in real time what it is. And especially because it slaves over into our Moberg machine, we can see, just like the examples that Laurence provided, how the waveforms throughout the shift or the last 24 hours differ between MAP and between SCPP and ISP. And so that's really great. We're definitely learning to use that a lot more in our complex neuro patients, and it's been really fun. All right. Does the patient have to be positioned on his side? Only for the placement. And, you know, just like an epidural placement or a lumbar drain placement, it's just for the side. And then once it's taped and secure, and we tape it up over the shoulder just for ease, the patient can lay on its back. They can sit up at a 45-degree angle. They could sit at the edge of the bed. So, you know, as long as, just like with orthostatic hypotension, we want to monitor the SCPP as there are position changes, especially in the first couple of days. But there is no restriction to the patient mobility just by having this there. And usually our patients, it's placed at the bedside after OR, just so they can get out of OR and into the ICU as soon as possible, just to get the better multimodal monitoring set up. And then they'll place the catheter there at the bedside, but it also could be done in the OR. Do you use antimicrobial impregnated catheters or prophylactic antibiotics while the fecal catheter is in place? Have you found any increased infection risk secondary to this catheter placement? So I do not know about antimicrobial impregnated catheters. I would have to ask one of the surgeons about that. And I can leave my email in the comments if anyone wants to reach out to me, and maybe I can let you know specifically. We do not use prophylactic antibiotics other than what we would for surgery. So if the patient went for a decompression, we usually give 2 doses of cefepime to any patient that gets a surgery that includes hardware. And so just standard protocol for that, nothing different for our spinal cords. And I don't know exactly what our data is showing as far as increased risk, but I know just recently there was one of the residents looked through all the data to see about what contraindications or what adverse effects were related to the catheter placement, and specifically with managing SCPP instead of MAP for the vasopressor requirement. And they did not show any infections related to it, but I don't know how many patients have come since he's done that analysis. So new publications will be coming out soon, hopefully. And this is all pretty new for us. Okay, based on what you've seen since the protocol, how long are these patients with the lumbar catheter on SCPP management? So what the literature says is 5 to 7 days managing MAP. And what we did before switching our protocol was manage MAP for 5 days and keep the patients pressed at a MAP higher than 85 for 5 days. So we just transitioned to managing the CPP instead for the first 5 days. So some studies have looked at it up to 7 days, but we just do the first 5 days that we press them. And then once the 5 days are up, we take the catheter out and we stop maintaining obviously looking at the CPP. Usually we'll try to just keep a MAP within a normal range above 65. Why don't you drain CSF if the ISP is too high, much like with ICP and TBI? It's a good question. So I think the theory is that the cord is likely not surrounded by CSF, just because due to swelling at the injury site, it's probably compressed against the dura. So because of that swelling, it's unknown whether draining CSF will really have any utility. So for now, we're just monitoring it, but it is a thought out there, and I do know there is a study that did that. So I'm interested to see if that helps, but for our protocol, we aren't doing that. So how long are these patients usually intubated? No different than patients where their MAPs are monitored. So the catheter itself hasn't changed the patient's respiratory status or length of stay or length of intubation days. So I think typically, of course, it depends on their initial AIS when they come in. We only place these catheters in patients with an AIS grade of A, B, or C, and then sometimes D, depending on
whether the attending wants to or not. So these are definitely our more severe spinal cords, and so depending on the level at which the spinal cord injury is, and the severity, and if they have polytrauma, a TBI associated with it, then that kind of depends on how long they'll be intubated. In patients with both TBI and SCI, with a concern for increased ICP related to TBI, is the lumbar drain contraindicated? Have you been looking at SCI alone? It's a great question. So we, if we're gonna put monitoring in the head, I believe then we do not in the spinal cord. So I think we've only had, so we will have spinal cord injury patients that have an associated traumatic brain injury, but not to the severity where we would put in intracranial monitoring. So I'm trying to remember, I think there was one patient in which we did have to put intracranial monitoring in, and we did not put spinal monitoring because of that. Because we wanted to monitor the maps anyway for the TBI, I think that just kind of took precedence, but it'll be interesting to see. In the studies that have been published, having a traumatic brain injury was an exclusion, so none of the patients that have been looked at in the recent publications had a traumatic brain injury, so I think it's really unknown in how to differentiate the management. It'll be interesting to see. If SCPP is elevated and or if we have an abnormal waveform, what are some interventions neurosurgeons would look into after nursing management with pressors has been done? Well, we haven't really identified an upper limit of spinal cord perfusion pressure. We know we want it above 65, and as long as we're maintaining that, then you know, I guess if the spinal cord perfusion pressure was getting high, then obviously the map would be pretty high too, and maybe we would discuss what to do then. But typically in these patients, they struggle with hypotension, so we're really trying to get that number up. As far as an abnormal waveform, you know, I've never actually encountered that. I think we've had dampened waveforms, but enough to where the spinal cord perfusion pressure is kind of trending with the map, so we feel confident to continue to monitor that. I guess if the waveform was bad, they could always replace it, but I've never actually seen that happen in our patients yet. And yeah, I think that answers your question. So, yeah. Thanks. Is there a documented higher guideline compliance using the CNS reader tools? I wish. I think that will be our next step. We just kind of rushed this out when we got that new paper, and all the attendings are really excited to start this new protocol, and so we did that. And now we're learning how to at the bedside, you know, manage it better with our CNS reader and our Moberg. And I think our nurses are slowly becoming all on board as far as using the CNS reader to look at these things, but there still is more education needed. And I think, you know, right now they're just wanting to make sure that the patient care itself goes okay, because it was still kind of new. But once we get a standard protocol in place for using the reader, that would be an interesting thing to disperse. Do you know how closely cerebral perfusion, I think that's CERPP, cerebral perfusion pressure, correlates to spinal perfusion pressure? I don't actually. I don't actually think I can answer that question because we don't usually have intracranial monitoring and spinal monitoring at the same time. So I'm not actually sure what the literature shows if that's been looked at before, like in animals. So I'm not sure. I think just thinking at it pathophysiologically that they would be relatively the same, and they are, you know, calculated from a map, but I'm actually not sure. What is the highest pressure you have measured? Is this spinal cord perfusion pressure? I'm not sure what you're looking at. If it's spinal cord perfusion pressure, there's a paper that goes all the way up to 120. And we just, our goal is to keep it above 65, and usually we're needing to use medication to get there. So typically it'll hang around 60 to 70s, maybe lower 80s, just because, and then usually after the first couple days, once the perfusion pressure starts to level out, we can say it got higher. I think the highest one I've ever seen is maybe just around 100. I think in the literature, there's one study that said to keep it under 90, I believe. But I think there's just a lot more data needed to know what that high threshold would be, and what the negative effects of hyperperfusion would be. I think right now they're all looking at hypoperfusion. And right now, we know that we should be keeping it, or the more that spinal cord perfusion pressure drops below 50, that the relative risk of you not having neurologic recovery increases. So we chose to put the parameter at 65, just to be safe, but it'll be interesting to see what else. Are you aware of any literature that shows improved spinal recovery if SCPP is kept above 65? There was a study that said that the, so not the square study from the camper study that published, saying that the more you dip below 50, it increases your relative risk of not having neurologic recovery. There was another study that said that your risk of not having neurologic recovery starts to increase at 60. And I don't know what the sample size of that was, or much about the study, but Laurence and I were just talking about it, and he had said that. And so I think we just elected to go to 65 because there hasn't been any negative outcomes associated with being any higher than that, and we figured we'd rather be safe knowing that hypoperfusion is definitely associated with not having improved neurologic outcomes.
So Deb, thanks a lot. I think we're running out of time now, unless there's other questions there.
Thank you. Thanks for all the questions. Thanks for tuning in.
Well, Deb, thank you very much, and I really appreciate your time in doing this. This was one of the more fun webinars for us to do. Please pass our thanks on to Laurence, and a speedy recovery from his tooth problem.
Yeah,
I will. There you are, and we'll see you next time. Thanks so much to all of our viewers, and please stay tuned for our next webinar. Thank you.
Thanks, everyone.